ECMO at the right time. Thus, the necessity for ECMO awareness program. With this, I would like to welcome our honorable dignitaries onto the dais. Let's give a huge round of applause for our respected Dr. Alok Chandra Agarwal sir, Dean, Professor, HOD, Department of Orthopedics. Let's give a big round of applause. Renu Rajguru ma'am, Medical Superintendent, Professor and Head of the Department of ENT, AIIMS Raipur. We welcome E. Agarwal sir, Professor, HOD, Department of Anesthesiology and Critical Care. Dr. Nitin Kashyap, Additional Professor and HOD, Department of Cardiovascular and Thoracic Surgery. Dr. Chinmay Panda, Associate Professor, Department of Anesthesiology and Critical Care. To all the honorable dignitaries, welcome to the program, sir. Meeting ceremony. Let us invoke the blessing of the Almighty with an invocation song. Consequently, we will be lighting the lamp also.
As we all know, already she has described, the aim of today's gathering is to shed a light on a critical aspect of the healthcare, that is ECMO, extracorporeal membrane oxygenation. So ECMO is often referred to as a life-saving technique, plays a crucial role in supporting the patients with several severe lung and heart conditions. It is a bridge to recovery for those facing life-threatening situations. As we gather here, it is essential to understand the significance of ECMO and its role in the patient's life-saving. The motto of our awareness program is succinctly captures the essence of our mission, that is saving life and transforming care. This motto underscores the transformative impact that awareness can have on utilization of ECMO as a medical intervention. In brief, the ECMO awareness program strives to achieve an interdisciplinary collaboration among healthcare departments as witnessed by the diverse expertise represented by our esteemed guest today. Inspiring hope by demonstrating how ECMO serves as a beacon of hope for patients facing life-threatening cardiac and respiratory challenges through a success story. As we embark on this enlightening journey together, I encourage each one of you to actively participate and engage in the insightful discussion and carry the knowledge gained here into your respective spheres of influence. It is through collective effort that we can make a significant impact on healthcare and contribute to a future where ECMO becomes an even more accessible and effective life-saving tool. Once again, a warm welcome to all present, and let us collectively work together towards the saving life and transforming care through our ECMO awareness program. Thank you and welcome you again.
The success story of ECMO in AIIMS Raipur. Let us give a huge round of applause to everyone, especially Department of Anesthesiology and Critical Care and Department of Cardiothoracic and Vascular Surgery for the continual dedication. Now I request our respected Dean sir, Professor Dr. Alok Chandra Agarwal sir, to facilitate Mr. Jitendra.
arranged to felicitate of the treatment. Since I joined the department, from day one I am seeing his dedication and his sincerity towards the work. From day one, I see him working from 9 to 9 without complaining, untiring efforts. And when I become HOD and give in charge of ICU, since 3 years he is giving almost 12 to 13 hours and daily on emergency for ICU and saving a lot of patients. Every month he comes to me and says, "Sir, hum ye kharidenge, sir, hum wo kharidenge." Ultimately, we could purchase so many things, and this is the second patient we manage on ECMO, and the patient is with us. He is sitting here, and that is
I congratulate Department of Anesthesia, HOD Dr. Chinmay and all present here on starting this ECMO awareness program. Everything is a teamwork. Patient care is a teamwork, but some people have to take the lead and initiative to fructify the efforts.
MD, Mr. Gravindra, Sheikh, let's.
So you see the spectrum of extracorporeal life. Suppose sweep gas flow rate. This is how it increases CO2 clearance without affecting the oxygenation. And then ECMO consists of central unit controller, which control for the patient on ECMO. You have to select the right patient for the right indication.
Good morning, all. Today I am going to present you one of the interesting case which I recorded in mid of the November. Management part, mostly Dr. Jitendra sir covered everything. So now here I will discuss how we were implicated that modality into our patient. Now coming to history of patient, is a 28-year-old male patient presented to emergency department on 15th of November at around 6 p.m. with an alleged history of RTA on 7th of November at 4:30 p.m. The mode of RTA was two-wheeler hit by four-wheeler near rider. At that time there was no history of loss of consciousness and it was not under the influence of alcohol. There was no history of ENT bleed, no history of headache, vomiting and seizures. From there, he directly went to his home. After staying at home for 2 days, he gradually developed shortness of breath and severe chest pain, which was increasing with deep inspiration. So, with these complaints, he went to his nearby hospital. On evaluation, they found left clavicular fracture and left second, fourth, fifth rib fractures with left-sided pneumothorax. And there was left-side pleural effusion with collapse of underlying lung was there. And there was a small defect in the left heavy diaphragm with subdiaphragmatic collection was there. And patient was having pain abdomen and abdominal distension. For that they evaluated, they have done CECT abdomen. In that they came to know that patient is having multiple splenic lacerations of more than 50% with perisplenic hematoma, for which they have done diagnostic laparoscopy with lavage and they have inserted a drain on 10th of November. And they were not able to extubate the patient. Patient was on ventilator only. Some subsequent day, there was difficulty in ventilating the patient. So they planned to drain the effusion, for which they have inserted ICD. And patient subsequent next till 15, patient was on the surgical ICU, and he was having lung contusion. In view of that prolonged mechanical ventilation, they have done tracheostomy on 15th of November. For further management, they have referred the patient to AIIMS Raipur. On arrival to AIIMS Raipur, on general examination, patient was conscious, coherent with GCS of E4 VTM6, and there was no pallor, icterus, cyanosis, and there was no clumping, edema, and lymphadenopathy. Patient vitals pulse rate was 104, BP was 123/80. And respiratory rate was 40 per minute, which was on spontaneous mode. On systemic examination, CVS S1 S2 were heard, there were no murmurs, and in respiratory system there was decreased air entry on left lower lobe, and there were bilateral basal clefts were there. For abdominal examination, abdomen was distended with with the drains were in situ. In CNS examination, there was no focal abnormality. So Till next 2 days, patient was in trauma ICU, and on 18th of November, patient developed a respiratory distress, and we got call for transfer of patient to CCU. For the next 3 days, 3 days of period, patient was slowly developing high grade of fever, and his tracheal secretions were increasing, and his FiO2 requirement was also increased. So we escalated the antibiotic. Previously, Pictus was given, so we escalated it to colistin and estrada, and we tried to give lung productive ventilation. Daily radiological imaging was done, and ABGs were 6,000 ABGs were done. In that, we came to know that his ventilation and oxygenation was deteriorating. On arrival to CCU, initial days PaO2 was 200, which was reduced to 60, and PCO2 was gradually increasing with 33 to 140. So we tried to all of the modalities which were advised by ARDS night protocol. We followed everything, and we tried to give sedation and paralyze the patient. With that also, we are not able to ventilate the patient. This was the ABG taken on 22nd of November. This was at around 1 p.m. ABG was showing pH was 7.059, PCO2 of 142, PO2 of 51, PF ratios was around 51.5. So after paralyzing and ventilating the patient also, there was no lot of improvement. In the evening 7 o'clock, the ABG was showing pH of 7.2 and PCO2 of 90, and PF ratios were around 61. This was HRCT taken on 21st of November. In that, you can see total right side was completely consolidated, and left side middle and lower lobes were consolidated. Total right lung was consolidated, and left lower lobe and middle lobe, middle segments were consolidated, and each category stage 3 ARDS diagnosis was done. And 22nd X-ray was showing right side lung was completely consolidated, and left side there was mild effusion and patch was there in middle lobe. As per American Thoracic Society, here I want to present 2 guidelines. One is from American Thoracic Society, another one which they are using in Eulia trial. From American Thoracic Society, as per American Thoracic Society guidelines, these modalities are strongly recommended. Like if the patient is having mild, moderate, or severe ARDS, in that you should give lung productive ventilation. If the patient is having moderate or severe ARDS, we can try prone ventilation and high PEEP modality. And if the patient is having severe ARDS, we can do neuromuscular blanket and ventilation. So in our patient, we have tried all these modalities, but there was no improvement. So we were last option for was VV-ECMO. And this chart I took up from Eulia trial. In their study, they have mentioned that if the patient PF ratio is less than 150, the PF ratios are less than 150, they tried prone ventilation and neuromuscular blockade and high PEEP settings. We tried all those things, and ECMO fulfilling criteria in the study was PF ratios less than 80 for more than 6 hours, or PF ratio less than 50 mmHg for more than 3 hours, or pH less than 7.25 with PCO2 of more than 60 for more than 6 hours. This was the criteria they used in the study. So our patient was fulfilling this criteria, so we straight took him to ECMO. In their study, they have followed one more thing, this Murray scoring. In this also, the patient, our patient PF ratios were less than 100, which was like around 50 to 60, and in chest X-ray, almost 3 quadrants were involved. We used PEEP up to 14 people used in our patient, and and lung compliance was around 3, which was like less than 90. So he fulfilled this criteria also. Picture on second day of ECMO. As already Jitendra sir told you about mission, this is the ECMO machine. This is the oxygen bladder, and the pump will be somewhere here, and this is the oxygenator. This above one is the arterial cannula. We have used 19 size, and here femoral vein, we used venous cannula, which was 21 size. I try to conclude the total 10 days period of ECMO in one slide. In initial 2 days, our ventilator settings were patient was on ACPC mode with P-inspiratory pressure of 22. With peak 22, he was he was generating up to 30 to 80 ml of tidal volume. Respiratory rate was 12, and the patient lung compliance were only 3. Here the ECMO settings were FiO2 of 1, sleep gas flow was 6 liters, with 3,800 of RPM, we were able to achieve 5.5 liter of blood flow. Next subsequently next 3-4 days, we gradually able to improve the tidal volume up to 170 ml with P-inspiratory pressure of 15, and compliance also slowly improved from 3 to 14. So already we were escalated the antibiotics to estrogen and colistin, and this was sensitive to that, so we continued the same treatment. And after initiation of ECMO, we set 1% of cultures. In that day 4 of ECMO, we came to know the patient, there was candida growth in blood. So we have added capsofungin, 70 mg loading dose with 50 mg OD. And the procal was at that time 33.7. Gradually it was improved over a period of 5 days, it came down to 11. Before initiation of ECMO, he was in sepsis, so his creatinine level was 3.1, which was gradually improved over a period of time. And by the end of like day 10, with 30 P-inspiratory support, we were able to achieve almost 520 ml of tidal volume, and compliance also improved up to 34. And we slowly reduced the FiO2 to 0.3, and sleep gas flows were reduced to 1 liter. And in the 4th of December, you can see here, like initially there was complete right lung was gone, but now regression was there, and left side there was mild patchy resolving consolidation was there in left lung, and you can observe in this X-ray also the right lung was now fully regressed. This radiograph was taken on next day of decannulation. We made it out of it. This one was after 2 weeks. He was able to walk himself. This was the team behind hard work.
Thank you, Sai sir. Next, I would like to welcome Dr. Chinmay K. Panda, Associate Professor, Department of Anesthesiology, for his presentation.
I want to thank you for your presence over here. So next part is we have also involved the patient's family members in the patient's care. We always told them to come to the patient, talk to the patient when he is getting conscious. In between he is getting conscious, then we started talking with the patient so that the family members should feel comfortable themselves, as well as the patient should feel comfortable that he is not in a foreign environment. It was discovered at that point of time nobody wants to undergo a CPD because that may be the fatality rate will be more. the surgery which we nowadays we are doing would not have been possible if we have not taken up those procedures on that days. So this procedure also may get the patients who are terminally ill or who is going to die. We can put those patients on ECMO with proper indications, may get some benefit. So this.
At the site, then routine tracheostomy care with the gauze and betadine swab, for his guidance and training and continuous support to make all of us confident and skillful in giving out the care. Last but not least,
Thank you so much.